Hi everyone. I'm Dr. Mona Sazgar and I am an epilepsy specialist at the UCI Medical Center, UCI Health. And my special interest and my publications are in women with epilepsy. So my passion is treating women with epilepsy, especially women of childbearing age, but any age really. I would like to treat and manage and to hopefully be able to help. I start with a case, and this is one of the cases, one of my own patients. SB is a 28-year-old woman with a long-standing history of focal epilepsy, and it was coming from the right frontal area, and it was due to an abnormal tissue that was in there congenitally. The patient was born with it, but she didn't know about it, and she went through college and started having seizures later in life. She used to experience clusters of seizures about a couple of days prior to her menstrual cycle, and then some of her seizures progressed to become bilateral, basically grand mal seizure, bilateral tonic-clonic activity. In the past couple of years, she was completely stable on oxcarbazepine, 900 milligram twice daily, and reported basically no seizure recurrence. So she was happy, everything was good. When she started dating, the physician started to put her on folic acid, just in case that she becomes accidentally pregnant, which is more than 50% of the cases in the United States. So she was put on folic acid, and then she got married a year before, was taking birth control pill, which was a combination of estrogen and progesterone. And now she comes to a neurologist and she tells him that, you know what, I'm pregnant. And she has a million questions because, first of all, she started having a couple of auras, again, a couple of the focal seizures that she had, which she didn't have in 2 years. Second of all, she's pregnant and she was on birth control. She was not supposed to be pregnant. And she's worried and she wants answers. This brings us to our talk about women with epilepsy, and what I'm going to go through is basically catamenial epilepsy, the epilepsy that fluctuates with hormones, the pregnancy, birth control, everything that you may have questions about in the life of a person who has epilepsy and who happens to be a young woman. Women with epilepsy face a number of challenges throughout their life, and the special concerns starts from the time of menstrual period, starting from puberty, all the way through birth control, conception, pregnancy, childbirth, childcare, and all the way through menopause. My presentation starts with defining what catamenial epilepsy is. I'll talk about the birth control and seizure medications, the interactions with the seizure medications. I will talk about what happens to the seizures during pregnancy. That's a question of a lot of women. When I become pregnant, is my seizure going to get worse? Is it going to get better? What's going to happen? And then the use of seizure medications during pregnancy. Is it safe to my baby? Well, am I going to damage my baby with taking these medications? And then we talk about the folic acid and breastfeeding. Epilepsy basically means a seizure disorder. It means that you have recurrent seizures. Your brain has the ability to produce seizures over and over. About 1% of population anywhere can have epilepsy. So no matter where in the world you are, from 100 people, 1 person may have epilepsy. Half of these people are women. So basically, in the United States, if you count, that would come to about 1.5 million women that live with epilepsy. About 24,000 of these women become pregnant. And so it's very, very important for the physicians to know all the issues and to be able to address them with women and about counseling them. So when they sent actually questionnaires to physicians who treat patients with epilepsy, they found that some of them have no idea that the birth control medications, the seizure medications may interact with them. It may make them ineffective. They didn't know that the seizures can affect the endocrine system. A woman's fertility can be affected even with the seizures or with the seizure medications. So there's a whole lot of things that even the physicians were not aware. So it is absolutely important to make that connection and to make that education happen. What does catamenial mean? Catamenial is from a Greek word called katamenius. Katamenius means monthly. So it was like a physician, Sir Charles Locke, that described this in 1857, and he found that some of the seizures are fluctuating around the time of menstrual period. Then there was another physician, William Gowers, in 1881, that said, oh, you know what? The majority of my women patients seem to have worsening of their seizures at a certain time of the month, and especially perimenstrually. So those were the pioneers in actually telling us that there is something about the seizures that could be hormonal. The pattern of seizures, when it fluctuates with hormones, we call it catamenial. Now, there are 3 types of catamenial epilepsy. And some of the people have worsening of their seizures about 2 or 3 days prior to menstrual period, during menstrual period, maybe a couple of days after. And that is because at that time there is the sudden drop in the progesterone in the blood. So the progesterone drops, that's a good hormone, that's the protective hormone. And when it drops, the seizures may worsen. The other time of the month that the seizures can worsen is at the time of ovulation. Ovulation is usually counted backward. The time that you have menstrual cycle, 14 days prior to that was the ovulation. So usually that's how we calculate that, and that is because you have a surge in the bad hormone. You have a surge in estrogen at the time of ovulation, and that can worsen the seizure. And if the ovulation does not happen, the people who have anovulatory cycles, those people can have for the rest of that half of the month, they can have worsening of their seizures. That brings us to the 3rd type of catamenial epilepsy. So we have 3 different types of catamenial epilepsy depending on the fluctuation of hormone. Now, how important it is? Some people report up to 70%, but at least 30 to 40%, 33 to 39% of women with epilepsy have catamenial epilepsy. This is a graph that one of my colleagues in Boston, Dr. Herzog, published this first, and it is basically showing the worsening of seizure. These boxes shows the perimenstrual around the time day -2, -3 to the day +3. Day 0 is the day of the menstrual cycle. That's when the menstrual cycle happens. So what would be the ovulation? Day -14. So when you go about -11 to -14, that's the 2nd type of catamenial epilepsy. And the 3rd type was this one. If the ovulation doesn't happen, all the hormones are out of whack, and that is when all the worsening is happening. How do we determine catamenial epilepsy? There are 2 things. One is seizure calendar. We ask people to keep track of their seizures, how many seizures in what day they had. And one is either ovulation kit or the temperature, the basal body temperature. That's not as accurate as the ovulation kit. When you have the ovulation kit, you know that you ovulated that month. If your seizures are 2 or more times more frequently happening around that certain time of the month, then you have the catamenial epilepsy, you have this type of epilepsy. Now, if you look at the sex hormones, we already talked about it. Estrogens are pro-convulsant, meaning that estrogens can worsen seizures. When you look at the EEG, when somebody has high level of estrogen, you have increase in frequency of spikes, sharp waves on the EEG. Progesterones are the opposite. They are anti-convulsant, and they may have the ability to protect against seizures. In the brain, there is an axis called hypothalamus pituitary ovarian axis. So there are 3 structures. Deep in the brain, there's a hypothalamus that produces hormones that will release sex hormones. So they are precursors of the sex hormones. So they affect the pituitary gland. The pituitary gland produces FSH and LH. Those are the 2 substances that can affect ovaries in order for the follicle to stimulate and for the egg to form. And then if the egg is not fertilized, and if you don't become pregnant, then that ovum, that egg will shrink, and eventually you have a drop in both hormones, estrogen and progesterone, and that's when the bleeding happens. So, and then the cycle continues, the cycle of the growth of the ovarian follicle, and then going through the whole thing. So why are we discussing this? Because there are structures in the brain that are stimulated by seizure, and they affect these axes. They affect your hypothalamus, pituitary, ovarian. So meaning that one of these structures is amygdala. This is a deep, deep nucleus. You see that in here. I think, does the mouse work when I point to it or no? Okay, so I have to come here. So this is your amygdala. It's a tiny, tiny structure deep in the brain, in the temporal lobe, close, adjacent to temporal lobe. If you remove that in people who have temporal lobe epilepsy, you can make them seizure-free. The chances that they become seizure-free is more, because that structure is very much stimulated during the seizure, and it is involved in creation of the seizures of the temporal lobe. Now, if in animal models, when they started stimulating the lateral aspect of the amygdala, they were able to create an ovulatory cycle in those animals. So ovulation doesn't work as well if you are stimulating that. They also can develop polycystic ovaries, the cysts in their ovaries, those animal models. So can you imagine somebody who has temporal lobe epilepsy and the amygdala is stimulated constantly? It does have a lot of connections to the HPO axis, the hypothalamic pituitary ovarian axis. So it can basically mess up your whole endocrine system, your ovulation, and affect that. That's why you see a lot of hormonal disorders in people who have epilepsy. So seizures themselves may disrupt this axis. You can have polycystic ovary as a result of that. You can, it's much higher in the population of patients with epilepsy than it is in the general population. And you can have abnormal menstrual cycles, either too long or too short. You can have low androgen. You can have premature menopause. People with epilepsy, they can go through menopause much sooner than general population. And basically, the fertility may be affected by this. The AED stands for anti-epileptic drugs. So that's what, when you see AED in my slide, just those are the medications that are used for epilepsy. Not only the seizures, but the medication that we use to treat seizures can affect the hormonal aspect and can affect your endocrine system. So the seizure medications, like there are certain medications such as valproic acid that can increase the polycystic ovary. There are medications that can disrupt all of these hormonal conditions. There are medications that are enzyme-inducing, meaning that they affect your liver, and they affect the enzymes in the liver. Dilantin, the phenytoin, carbamazepine, which is Tegretol, phenobarbital. These can affect the hormones in the body because they are enzyme inducers, meaning that they are all competing through the same liver. If you have those medications, your hormones are going to drop. The level of certain hormones in your body is going to drop. And again, there are certain medications that can affect the sexual function. There are certain medications that can eventually result in early menopause. And there are certain medications that don't have as much of an effect. For example, with levetiracetam and with lamotrigine, the endocrine side effect is not as much, but we have to be careful because all of the medications to some degree can have that kind of an effect. So what to look for? Physicians should look for signs of weight gain, like more than 10% of the base weight. Increased body hair or facial hair, so loss of hair in the scalp, menstrual cycles that are either too short or too long, menstrual cycles that from one cycle to the other cycle, there's more than 5 days difference. And if there's any trouble with sexual desire or arousal. If you don't ask, you don't know. So these are the kind of things that are on my questionnaire with every follow-up patient that comes to the office. They answer these questions, which means that we are able to detect it because they have to answer that questionnaire every single time that they are there. Otherwise, you may think that the medications are all very good and they're happily using it and there's no problem. So the contraceptive failure is a good possibility with medications that are competing through the liver enzymes. Same seizure medication, some of the seizure medications can result in the birth control to be not as effective, and we are going to show you which medications. So if you look at this, this is the most comprehensive list. This is actually going to come up in February in one of my publications in Continuum Neurology. Basically, all of the medications that can induce. So everything in red is going to make your birth control ineffective. Anything in yellow, if you use a high dose, it can make your medication the birth control ineffective. And then when you come to the green, these are the ones that do not cause contraceptive failure. So it is up to the physician and also to discuss it with the patient that there are certain medications that if you're on them, you have to have a second method of contraception. You have to have a barrier method, some other method, because your birth control is not going to make it. So that brings us back to our patient, SB, who became pregnant while was on oxcarbazepine. Oxcarbazepine is one of the medications that can cause induction of the liver enzymes, which meant that the birth control was ineffective. That was the reason she became pregnant. And now what could she have done? One thing is to use a birth control with higher level of estrogen, but we just said estrogen is a bad hormone. We don't want it. So that is, and then what happens with estrogen? You will have more risk of blood clot, you will have more risk of a whole lot of other things that can happen. So that's not really an option, although we know that there are certain birth controls that have that high estrogen. So what do we do? Well, there are other means of contraception. One of them is injection of Depo-Provera that, if you do it more frequently in women with epilepsy, that can protect them. The progesterone tablet only is not going to be effective, so forget about that one. The mini pill, those are not effective. The best method that we recommend is IUD. And IUD could be either the copper IUD or it could be the IUD that has progesterone release, and those are the Mirena and the Skyla. So any IUD is the method of choice I don't like Mac, so let's see. There we go. All right, we're good, I think. So how about there are certain medications that it's the other way around. So if you use the birth control, it affects the medication rather than the medication being, affecting the birth control. And one of them is Lamictal. When I put somebody on Lamictal, I tell them the moment you go on birth control or the moment that you become pregnant, you have to let me know immediately because your Lamictal is going to drop dramatically and you're going to have seizure recurrence. So with the lamotrigine, you have to make sure that you tell the patients that the estrogen can affect your birth control, your medication. We just said that 24,000 women with epilepsy become pregnant each year in the United States. And usually when I counsel them, I quote this, which is the latest that we have, what happens to seizures during pregnancy, that in about 20 to 35% of women with epilepsy, there may be worsening of their seizures when they become pregnant. In about 55%, there won't be any change. And about 10%, they may have better seizure control. Now, having said that, there is another study on patients with catamenial epilepsy. So these are 59 women that were followed, and these are people who had hormonal epilepsy, catamenial epilepsy. And there were 215 people that didn't have hormonal fluctuation, but they had epilepsy. When they followed them through pregnancy, they found out that actually about 79.7%, 80% of women who had catamenial epilepsy, they remained seizure-free during their pregnancy. That's good news. That compared to 22% of people that didn't have catamenial epilepsy, meaning that there is one good thing for catamenial epilepsy. If you become pregnant, at least it's more protective. So that's from all the news that we give them, that one news is actually a good news. And when they looked at the seizure reduction, about 50.8% of catamenial group had seizure reduction, as opposed to only 8% of non-catamenial. So in this case, pregnancy is more protective in patients with catamenial epilepsy. What are the causes of seizure recurrence in somebody who becomes pregnant? Number one, not taking the seizure medication. I have patients who just say, okay, I just stopped my seizure medication and I'm waiting to come and see you. I want to just scream. I'm like, no. If you have a seizure, it can be much more harmful to the baby than the medication, depending on the medication that you're on. So a lot of times we try to know whether the patients are planning to become pregnant. Hopefully they plan, and then we can counsel them before that. But unfortunately, it's not we don't always have the luxury of knowing in advance. So what I do is that constantly I try to monitor my patients and assume that at some point in the near future they're becoming pregnant. So meaning that I have to make sure that their medications are safe, that they're on medications that are less harmful during that pregnancy. Especially there are other reasons that people can have, like the stress of pregnancy itself can bring out the seizure, the increased estrogen to progesterone ratio. There are some medications that are reduced significantly. We just talked about lamotrigine that drops significantly during pregnancy. So those are all the reasons that they can have seizure recurrence. Especially with certain medications, lamotrigine, oxcarbazepine, carbamazepine, phenytoin, phenobarb, and Keppra, the levetiracetam. These medications, if you have them, if you are on these medications, you have to be monitored more closely during pregnancy. And I usually do monthly levels of the medication, and I compare it with baseline and try to match the baseline level of their seizure medication. Serum concentration of these medications may drop again significantly during the pregnancy. So what happened to our patient? We are going to go back to our patient in every single of this. So she not only became pregnant, but pregnancy caused the oxcarbazepine level to drop. And that was the reason that she was experiencing a couple of auras. So what happened is that we increased the dose of oxcarbazepine to the appropriate level, and then after delivery of the baby, we try to back off and then go slowly back to what she was prior to the pregnancy. So how does seizure, seizure and epilepsy, how does that affect pregnancy and the baby? There are two categories of risks. There are risks that are involved as a result of seizure, and there are risks that are involved as a result of seizure medication. The seizures themselves, independent of seizure medication, can be harmful. And those are the risks that you see. Greater risk of trauma and falls, greater risk of premature labor. Women with epilepsy may have that. The intrauterine growth retardation, IUGR, low birth weight, stillbirth, perinatal death, miscarriage, fetal hypoxia, meaning that lack of oxygen and acidosis at the time of birth, and sometimes heart distress, the fetal heart rate suppression. These are 2 times or greater in people with epilepsy than in people who don't have epilepsy and become pregnant. So when you look at the epileptic seizures, the seizures themselves can increase the risk of birth defects. And there were a couple of older studies that showed that even if you're not on seizure medication, having seizures and having epilepsy increases the risk of having a child with some more problem than the general population. And the risk of morbidity can increase 10 times with the seizures. So I tell my patients that stopping seizure medication is not an option. That is not what you do when you become pregnant, because being on certain medication can be safer than having seizures and uncontrolled seizures during the pregnancy. So what are the risks? What is the risk that we quote? Up to 10% risk depending on the medication that you're on. And again, I'm going to present to you in the next slide the breakdown of every single medication that we know, and this is from the North American Pregnancy Registry data. The kind of malformations, the kind of problems with birth defects that you get with some of the seizure medications is mostly midline. So basically, cleft lip, cleft palate, midline heart problems, midline skeletal problems, spina bifida, and also some language acquisition, so the cognitive and language delay. In about 1.2 to 6.2% of women with epilepsy, there may be developmental delay and language acquisition delay in the child. So if you look at general population, like if you look at somebody who doesn't have epilepsy and who's completely healthy, on absolutely no medications, and they're taking their folic acid, and they become pregnant, the risk that the pregnancy is a risky business. There is still a risk. 97% chance that the baby is normal and healthy, but there is 2 to 3% chance risk in the general population that the baby may not be healthy, that there may be a major problem with the brain or heart. So it's not just epilepsy. In the general population, they have that risk. But in children that are born to women who are on seizure medications, that risk may be about 4 to 6%. The bright side of it is that you have 94% chance of having a healthy baby. So pregnancy, epilepsy does not exclude pregnancy. There's also increased risk of spina bifida with certain medications such as valproic acid and carbamazepine. So that is why they are put on folic acid to try to prevent that from happening. These are the list of a lot of pregnancy registries in the world, anywhere from Europe to North American to Australian to Swedish. There are certain drug companies. Everybody is looking at these seizure medications during pregnancy because this is a big question that women ask. What happens to my baby during pregnancy? And this is what I want to present to you. When you look at this graph, the worst one at the bottom is valproic acid. So this is the Depo-Provera. And that is a risk of 8.9%. So remember 2 to 3% in the general population, compare it to that. Although in this population, when you look at people who didn't have any seizure medication, it was even lower, about 1.1%. So no seizure medication, valproic acid. And then anything in between is gabapentin, zonisamide. This is the risk of oxcarbazepine. Our patient was on it, 1.7%. So it is actually not too bad considering that the general population risk can run around the same. This is the levetiracetam, the Keppra. This is the risk of lamotrigine. This is the risk of phenytoin, carbamazepine, and then also topiramate. So the green one is Topomax. And then below that is phenobarbital and the valproic acid. So from bottom to top is good, bottom is bad. And if you are on valproic acid or on phenobarbital or on Topomax, the risk is much higher in having a problem with the baby. Does that make sense? So this is the, oops, you're going too fast. All right, so these are the numbers. Again, valproic acid 8.9%, phenobarbital 5.9%, carbamazepine 3%, going down all the way to phenytoin, lamotrigine, and levetiracetam. These are the numbers that we have. With the lamotrigine, there's only one other problem. It can increase the risk of cleft lip and cleft palate. It is a cosmetic surgery to correct it, but still it is a risk. And it's about 8.9 per 1,000 birth. So when you look at it in general population, that risk is about 0.5 to 2.6. So that risk is increased. With Topomax, the risk is actually 6 times higher. So that means that usually we try not to be on Topomax during pregnancy. How about the cognitive function of the baby? There was a study by Mader and colleagues that they look at the pregnant women who took certain medications, and they followed their babies, and they did cognitive assessment over years to see what happens with certain medications or with seizures, and they found that the predictors of lower IQ in the babies up to 6 years after they followed them was, number 1, taking valproic acid during pregnancy. So number 2, having a mother who has lower IQ score. Number 3, the more convulsive seizures you have during pregnancy, the lower the IQ of the baby is going. So that's one of the things. And number 4, polytherapy, being on more than one seizure medication. So that's why we try to change to monotherapy, to have only one seizure medication rather than multiple. Try not to use the ones that were at the top of those lists, the ones that increases the risk to the baby. And then try to work with obstetrician, that is a high-risk obstetrician, to check the baby, to make sure that we detect any abnormality before the baby is born. With the newer medications, obviously the data is not as extensive as with the older medication, but it doesn't mean that they're safer. So we have to make sure that we keep following the pregnancy registries and find out about that. So absence of evidence doesn't construe as evidence of absence, meaning that if you don't know, doesn't mean it's safe. All right? So back to our patients. She was on oxcarbazepine, so it was actually lucky that she was on one of the medications that didn't cause as much of the trouble, and actually, like the risk wasn't that alarming. 1.7% is an acceptable risk. So she continued to be on folic acid while taking that, so there was no need to make any changes. What is folic acid? Why are we putting everybody on folic acid? It's an essential substance that is important in the growth of the baby. So basically, it's important in the DNA. Methylation is important in cell division. So when the baby is trying to be formed, folic acid is an important component of it. So that's why we all recommend people to take folic acid. And that's about 0.4 milligrams. In the perinatal vitamins, it's 0.4 milligram. Up to this date, there is absolutely no evidence that higher the dose of folic acid is going to be a whole lot more helpful. As long as you're on the perinatal dose of that, or maybe 1 milligram in patients who have epilepsy, you're safe. Because we know 50% of pregnancies are unplanned, automatically we put anybody who is in the childbearing age on folic acid, because that's the least we can do to save the baby if they become pregnant. There was a study by one of the doctors, Walt et al., that looked at 5 milligrams, looked at different doses of folic acid, and they found that there was about 85% protection when they were on that higher dose. But my next slide is what I always tell patients: too much of a good thing can be a bad thing. So mega doses that are very, very common these days of anything good, beware of that. Don't take anything in mega doses. The folic acid, when they looked at, there was a study in Spain that they looked at the children born to mothers who were on higher dose of folic acid. So if you are on, say, 4 milligram, 5 milligram or higher, and they found out that high doses of folate, even more than 1 milligram a day, may result in increased risk of small for gestational age. So smaller baby if you are on higher dose. The other thing was that if you're on higher dose of folic acid, there was lower level of cognitive development in children when they followed them at 4 or 5 years. So only consider higher doses on patients who are on enzyme-inducing medication, on phenytoin, which is dilantin, the carbamazepine, primidone. There are certain medications that make folic acid lower. So you just try to supplement higher level, but not in every patient. So normally I just tell my patients no more than 1 milligram of folic acid because I don't have any other evidence. And in fact, I have evidence to the contrary that higher dose could be helpful. Other pregnancy recommendation is definitely follow up with a high-risk obstetrician, close follow-up with epilepsy doctor, ultrasound first trimester, ultrasound again at 16 week or 17 week. That's when you see the full anatomy of the baby and you can tell whether they have any problem. And then there are other blood tests, the AFP test, there is like amniocentesis. If the woman chooses to do that, then those are other things that we can recommend. Usually I recommend that in the advanced age to do the fluid because there's a risk involved with the baby can be aborted with that, so you just have to be careful. The other recommendation is that try to use the lowest amount of seizure medication possible, but then remember, number one priority is to control the seizures. So sometimes we are kind of between, what do they call it, stone and a hard rock? Whatever you say. So it is rough because you want them not to have seizures because seizures can be more harmful, but you don't want them to be on too much medication because too much medication can be harmful. So some medications you have to follow both free level and total level of the medication. Carbamazepine and valproic acid are two of them. The last thing that I want to discuss is breastfeeding. That's another question that everybody asks. Okay, now what? The baby is born. Should I bottle feed or should I breastfeed? We know that breast is the best. The breastfeeding is shown over and over again that it reduces infant mortality. It causes fewer infectious diseases, it boosts the immune system of the baby, it lowers the risk of diabetes, it enhances cognitive function. So why wouldn't somebody want to breastfeed? So the recommendation is that at least the first 12 months, breastfeeding is recommended by multiple agencies in the world. But how about the seizure medications? People are worried that if I'm on seizure medication, could it be damage to the organs of the baby? Could the baby have liver problem or blood problem? Or could they become lethargic from the medication? Could they have difficulty with feeding or their growth and all that? Usually my recommendation is that if this is actually important, what is the exposure of the patient, of the baby to the seizure medication? There is an actual index that we can identify for every seizure medication, and if it is less than 10%, meaning less than 10% of the medication transferring to the baby, it is considered to be safe to do breastfeeding. There are certain medications that percentage is actually 100%, like phenobarbital, etosaximide, Zarantin, primidone, those are the medications. So no breastfeeding on those medications. But with carbamazepine, phenytoin, and valproic acid, it's about 3 to 5%. Remember, less than 10% is okay. With lamotrigine, it's around 10%, and with levetiracetam, it's about 10% or slightly less. But these medications usually are eliminated rapidly. Usually I tell my patient, if the baby is exposed during your pregnancy to that medication, that exposure was much higher than the exposure through the breast milk. So the baby knows the medication, the baby is already used to that medication. In fact, the baby may withdraw from that medication if you don't breastfeed. So I think the benefit outweighs the risk if they're already taking that medication. My problem is that when the patient all of a sudden develops epilepsy postpartum, like the baby has never been exposed to that medication, that makes it harder because then you know that this is a new medication to the baby. So back to our patient, SB gave birth to a healthy baby girl and continued breastfeeding since she was on the oxcarbazepine throughout her pregnancy. Up to 6 months she breastfed and then there was no problem with the baby. she had a few more auras after birth because of sleep deprivation and all the stress and everything else was going on. But right after that, she was back. When we adjusted the medication, she was back to being seizure-free, and she chose this time to use IUD because then she could plan her next pregnancy rather than this. So in conclusion, there are a lot of challenges with women with epilepsy, from the puberty all the way to pregnancy, to like how to use the birth control, and all the way to menopause. I have another talk on menopause and bone health and all that. So a lot of issues that it's important for the physician to know, and it's important to communicate. But knowing that is that if the proper recommendations are followed, the vast majority of women with epilepsy give birth to healthy babies, and at the end, I just want to make sure that we do raise awareness in general population with the doctors and with other people, so they feel comfortable dealing with patients, with women with epilepsy. There were a couple of, and now it's becoming old. This is the book of Controversies Caring for Women with Epilepsy that I published a couple of years ago, and there was a chapter review on women with epilepsy. But there is another book coming. It's Absolute Epilepsy and EEG Rotation, but it has a chapter on women with epilepsy. This is a bullet form book, so it's like the gist of it, what you need to know without reading a lot. So this is like every page is all bullet format and everything. It's almost like my PowerPoint has gone now to the book. So there's another chapter that's coming in Continuum Neurology also that has all of my graphs that you saw here. And that is it's called Continuum Neurology. It's a very simply written, so it's something that can be used. Thank you so much for listening, and I hope that it was helpful. Go ahead.
I'm on birth control to regulate the period, and I'm on Lamictal. Will that decrease the effectiveness of the...
You're on birth control that has both estrogen and progesterone, like it's a combination pill?
It's a low dose.
Okay.
But I have Seizure plans, so I can't have children. So
Okay. But if you are on a birth control that has estrogen, any estrogen can affect the Lamictal level. Now, if you're seizure-free, that means that your low Lamictal is fine. But if you're not seizure-free, it means that estrogen is bringing your lamotrigine level down, so you need a higher level of lamotrigine in order to become seizure-free or to have seizure control. So they need to know what your level was before going on birth control, and then try to match that after birth control. Yeah, but your doctor can send a level, and if it is in the lower range, it means it's because of the birth control. No problem. Anybody else? Thank you, guys. Enjoy the rest of the expo.